It's cold. Jacob, can you check if I'm audible once more? I'm connected to the headphones.
Yes, yes, ma'am, you're audible.
Is it clear?
Yes, yes.
Oh, okay.
So good evening, everybody, and welcome to one more national webinar at Believers Church Medical College and Hospital. And today we have a very pertinent topic, both for undergraduate medical students, postgraduates, doctors, and everybody. So that is treatment, diagnosis and treatment of tuberculosis. And we have an eminent speaker to speak to us. To introduce the speaker and to moderate the session, we have two distinguished faculty from Believers Church Medical College and Hospital. The first person is Dr. Jency Koshi, Professor of General Medicine at Believers Church Medical College and Hospital. She completed her MBBS and MD in General Medicine from CMC Ludhiana and went on to do her FHM at CMC Vellore, postgraduate diploma in infectious diseases from the School of Public Health and Community Medicine, UNSW, Australia, and got her tropical medicine certificate at CMC Vellore and Auckland University Hospital, Bergen. She has 25 publications in various national and international journals and a reviewer of journals. Excellent clinician and an amazing human being. It's a great privilege to have Dr. Jency Koshi, ma'am, in our panel. Welcome for this webinar, dear Jency, ma'am.
Thank you, Jacob, for your kind words.
And the next moderator is our dynamic pulmonologist, Dr. Ajay Matthew Joseph, who is joining us from Bangalore. He is our pulmonologist at Believers Church Medical College and Hospital. He did his MD pulmonology at the Rajiv Gandhi University of Health Sciences, Bangalore, and subsequently trained in allergy, asthma, and immunology from Vallabhai Patel Chest Institute, Delhi, diploma in allergy and asthma, and then followed by a training at medical thoracoscopy at the prestigious CMC Vellore. His special areas of interest are allergic diseases and immunotherapy and medical thoracoscopy for diagnosis and treatment of pleural disease. He's a fellow of the American College of Chest Physicians, USA, and a fellow of Asia Pacific Society of Respirology. Dear Dr. Ajay, it's a great privilege to have you here as moderator. Welcome.
Thank you, Jacob.
And now over to Dr. Jency, ma'am, to introduce the speaker, who is a good friend of her, and to hand over the session to the speaker. Over to you, Dr. Jency, ma'am.
Thank you, Jacob. It's my proud privilege to introduce Dr. Rajiv Karthik, who is currently working as the Associate Professor in the Department of Infectious Diseases at CMC Vellore. He completed his ID fellowship for from Tufts Medical Center in Boston and Masters in Public Health from Tufts University School of Medicine, Boston. He completed both his undergraduate and post-graduation from CMC Vellore, and he is one among the first candidates in the whole of India to complete DM in infectious diseases, that too from CMC Vellore. His areas of special interest are HIV, AIDS, and tuberculosis, about which he is going to talk about today. He's also a faculty member of short course in tropical medicine conducted by CMC Vellore, and also a part of the global health and humanitarian medicine course that is run by MSF. So over to you, Rajiv. We would be waiting to hear from you, so you can take over the meeting.
Thank you, Jency, for that introduction. And thanks to the organizers of this webinar, the Believers Church Medical College. And when I was first contacted for this webinar, I was actually thinking on what to talk about. And the whole world has moved to COVID and COVIDology over the last year. So I was trying to find a relevant topic which will be useful for everyone. And what better than to do an update on tuberculosis and see what has changed over the last year and what is new in the pipeline. So over the next 45 minutes or so, I'm going to talk about some basics about tuberculosis, some updates, and where we stand right now. So I'm just going to share my screen. Can you see my screen?
Yes, yes.
Okay. So I've titled my talk "Diagnosis and Management of Tuberculosis an Update." So let's just start with, we're sitting in your OPD or you're a medical student, and this is, somebody who presents to you. We see it all the time. A 36-year-old male, chronic smoker and ethanol consumer, presents with a history of prolonged fevers for 2 months duration, loss of weight of 10 kilos, poor appetite, some occasional cough, and chronic intermittent diarrhea. So when you hear this symptomatology, when you're sitting and seeing this patient, there are obviously some thoughts in your mind. The first clinical question you might have is, can this be tuberculosis? So for that, we need to know something about our local epidemiology. So that is one question that you would ask. The next you might want to know is, how can I confirm the diagnosis? And this is a very important field because things have changed over the last few years. How we used to view TB diagnosis has really changed over the last 5 to 7 years. Next is, what tests should I order, especially in a situation where there are several constraints and it's not possible to send all the tests. So what samples are justified in being sent? Is this MDR TB or is this drug sensitive TB? So obviously these are two ends of the spectrum, and we need to know at an early stage whether this is susceptible TB or resistant TB, and what treatment should we start. So by the end of this discussion, I hope that we'll be able to answer many of these questions far better than when we started. So I'll just touch on epidemiology, touch a little bit on clinical manifestations, spend a significant amount of time in diagnostics, and also on the principles of treatment. So we know that TB is one of the world's leading killers and one of the leading infectious agents to cause death. And it has been so for several years. And unfortunately, the burden falls on the low and middle income countries. So worldwide, there are about 2 billion people infected with TB, of which about 2.7 million occur in India, and about 450,000 people die because of TB in a year in India. And the burden of disease is predominantly seen in 6 countries. More than 60% of the cases is seen in India, China, Indonesia, Nigeria, Pakistan, and South Africa. And if you add Philippines and Bangladesh to this, almost 70% of TB cases are seen in these countries. So this is a disease that is predominantly seen in low and middle income countries. And the burden of the disease is faced by countries such as India and China. So again, top 10 TB countries, there's no sort of hiding the fact that we are number 1 in the absolute number of cases in TB. So these are some of the numbers I mentioned: about 2.7 million people who fell ill with TB, 445,000 deaths, and about 124,000 patients with MDR TB. TB is a very old disease, and there are several reasons why we have not gotten control over TB, and one of them is the epidemic of HIV/AIDS. And unfortunately, we are among the world's leaders in the number of HIV cases as well. So this HIV/TB has led to a resurgence of TB over the last 3 decades. And both TB has an impact on HIV and HIV has an impact on TB. People with HIV have a much higher risk of developing TB. The lifetime risk is almost 60%. And there's a faster rate of progression, which is about 10 to 30 times higher. TB also affects HIV in a bad way, in the sense there's an increased risk of developing other opportunistic infections and the increased risk of progression to AIDS, shorten lifespan. So this is one of the reasons why actually there is sort of a surge in the TB epidemic over the last 3 decades or so. So coming to some of the clinical manifestations, I must mention here that I think there is no specialty that will be spared about, with the diagnosis of tuberculosis. Every practicing doctor, bar a few specialties, have to think of TB as a diagnosis. So you need to have a high index of suspicion, whether you're an orthopedician, whether you're ophthalmologist, the ENT surgeon, gastroenterologist. So TB can present any of these different specialties. And unless you have a high index of suspicion, you will miss it. We also know that it can affect almost every organ system in the body, often more than one, so it can be confusing. There are rare symptoms, occasions where TB manifests with vague symptoms without any localizing features that may make it much more difficult to diagnose. So we know that broadly there are two main categories of TB. One is pulmonary TB and the other extrapulmonary TB. So pulmonary TB can be primary pulmonary disease or post-primary disease or miliary TB. And this usually presents with symptoms of chronic cough, weight loss, fevers. Extrapulmonary TB is a little more difficult to diagnose in terms of symptoms. It can be silent. It may not have a lot of symptoms. It may have symptoms just confined to that particular system. So some of the types of extrapulmonary TB are pleural disease, lymph node TB, skeletal, and bone TB. As I said, it can affect almost every single organ system in the body. And this is just a pictorial representation of the same. I'm really not going to spend too much time going into the different systems and the different manifestations. So we're taught from an early age the cardinal symptoms of TB: malaise, fatigue, anorexia, weight loss, chronic cough, night sweats, and hemoptysis. It would be easy if every single patient presented this way, but unfortunately it's not. And the diagnosis of TB, both the clinical diagnosis and confirmation of the diagnosis, can many a time be very challenging. TB can present because of some hypersensitivity reactions to the tuberculous antigens as well. And these usually manifest as something called tuberclids, which are skin lesions. It can manifest as flictinella conjunctivitis, and it can manifest as a sterile pleural effusion. So here you don't have actual tuberculous bacilli that can be demonstrated, and this is just a hypersensitivity reaction to actually the TB antigens. When to suspect tuberculosis? So this is usually a subacute to chronic disease, and when the nature of symptoms has been subacute to chronic, you will start to think of tuberculosis. The constellation of symptoms that typically would make one sit up and think of TB is fevers, night sweats, chronic cough, malaise, fatigue, and weight loss. Unfortunately, this syndrome complex can occur with a lot of other diseases, other infections, endemic mycosis, malignancies, autoimmune disorders. So this symptom complex is not particularly specific for TB. But if these symptoms are present, you should start thinking whether the patient has TB. Whether there's been any past history of TB or treatment with anti-tuberculosis therapy, history of close contact with somebody in the family or a work colleague or a roommate with TB may increase the possibility that somebody has TB. Healthcare professionals, unfortunately, we are at higher risk than the normal population. Somebody with immunosuppression, and we already mentioned that HIV infection is probably the highest risk for developing TB. The percentage risk of developing TB in somebody who's HIV infected is about 60%. Also, long-term steroid use, uncontrolled diabetes, and use of TNF-alpha antagonists, which are becoming more and more common, all are likely factors to predispose to TB. We are in an endemic situation, so this may not hold good for us, but if somebody has traveled from a non-endemic area to an endemic area and has stayed there for some time and is going back, that is a risk factor. And in the Western countries, especially US and Europe, people who develop TB are usually homeless or they are incarcerated in prison. One common manifestation of TB that we commonly come across is something called pyrexia of unknown origin, also known as PUO or FUO. It's defined as fever that is higher than 38.3 degrees centigrade or 101 degrees Fahrenheit that has been going on for at least 3 weeks. And the diagnosis is still not clear after 1 week of evaluation in the hospital. So this was a PUO definition from 1961. And since then, this has been subclassified into PUOs, which are neutropenic, HIV-associated, nosocomial, and classical. But still, classical PUO in an Indian setting, in our setting, extrapulmonary TB is a very, very common cause of FUO. Again, in the situation of HIV, opportunistic infections, the commonest infection seen in the HIV positive cohort is again tuberculosis. So these are two things that we need to remember. Extrapulmonary TB presenting as a PUO or FUO, and infections in the HIV positive cohort. So I'll just move on now to diagnosis. And there are a lot of diagnostic modalities that are available, and this has really changed over the last few years. Obviously, the topmost diagnostic modality is microbiology, and there are several different ways of diagnosing TB microbiologically. We then have radiology, we have histopathology, and we also have several miscellaneous tests. So TB diagnostics has really, come a long way from the development of the microscope in 1882 to culture methods which were identified along the same time, and chest X-rays in 1896. So these are diagnostic tools that have been available for more than a century. And till about 10 years ago, we were still relying on these tools to actually make a diagnosis of tuberculosis. So what sort of samples do we send for tuberculosis? So for pulmonary TB, the samples that are ideal are expectorated sputum sample, induced sputum, bronchoalveolar lavage, and lung tissue from a transbronchial lung biopsy. For extrapulmonary TB, it actually depends on the site that is involved. So if there's a collection of pus is a good sample. Various kinds of tissue, including lymph node, lung, liver, bone, brain, omentum, pleura or pericardium, and fluid from sterile sites such as pleural fluid, ascitic fluid, pericardial fluid, and urine. So if you look at this slide, you'll notice that there is no simple blood investigation that we can send. We all like that. We have a simple blood draw that tells you whether this is TB or not. That would make life very simple. Unfortunately, we don't have that kind of test that is available in the diagnostic armamentarium for TB. It has to be from the particular site that is involved, and it involves microbiology and histopathology. Why do we need an early and accurate diagnosis? We know that TB diagnostics are full of problems. And the main problem is that the delay it takes in making a diagnosis. And what happens because of this delay? So we know that an average Indian TB patient has a delay of almost 2 months and is seen by several healthcare providers before a diagnosis is made. And only 1 in 4 MDR TB patients probably gets diagnosed in the public sector. And this is not good, because by the time TB is diagnosed and treatment starts, transmission has already occurred. And here we're trying to say we want to reduce TB to as low a level as possible. But if you're not able to diagnose TB and start treatment early, then we're actually not preventing transmission. And what we aim to set out, what we're setting out to do, really will not happen. So this is just a graphical representation that actually shows you how long it is going to take before a person actually tests positive with the age-old diagnostic tool of smear microscopy. So the patient starts to feel unwell in the first month, starts having cough worsens, starts having hemoptysis. So he keeps going to different hospitals, different doctors, but tests like the AFB smear, which have very, very low sensitivity, are not going to be positive. And only when it reaches a certain level of about 10,000 AFB per ml, that is when the diagnosis is made. Extremely late, 5 months into the illness. The patient has become very sick, transmission has occurred to several people, and really, if we were continuing along these lines, there was no way we're actually going to control this epidemic. So remember from microbiology days, Zeal-Nielsen stain and the Orman-Floerman stain, that is what when we talk about smear microscopy, that's what we're talking about. It's very easy to do. It requires a very basic setup. It's very cheap. However, it has its problems. It cannot differentiate between species of mycobacteria, and its sensitivity is actually very, very poor. So probably the gold standard still of TB diagnostics is a culture. And from the microbiology practical days, you would remember this greenish media, that is the solid media, also known as Lowenstein-Jensen medium. And that was what was initially used to grow MTB. But it is a very, very slow growing organism, taking weeks to grow. So it was not acceptable to have sort of culture media that required several weeks to grow. And there have been improvements in that. We use now liquid media like the Middlebrook 7H, where the mycobacterium actually grow much faster. There are also automated mycobacterial culture systems like the MGIT 960 or the MDBAC, which actually use either oxygen utilization or carbon dioxide production to automatically flag up when there is actually growth. What about susceptibility tests? So we need to know whether there is Mycobacterium tuberculosis growing, and then we need to know susceptibility tests. And if you take conventional culture-based susceptibility on either an LJ medium or a midget automated medium, again, it takes time. The liquid medium is slightly faster than the solid medium, but still it's going to take several weeks. And with multi-drug resistant tuberculosis actually increasing so much in India and other parts of the world, it's not acceptable to wait 6 to 8 weeks to get a diagnosis of MDR-TB, and we really need something faster. And that is where these novel rapid molecular methods have come in, and I'm going to spend a little time talking about them in the next few slides, like expert MTB, rifampicin assay, or the line probe assay. So the conventional drug susceptibility is done on a solid medium by the proportion method. It's an age-old method, and you can do it for both first and second line drugs. And we usually get the results in 6 to 8 weeks. Automated liquid cultures, susceptibility on that is much more expensive, and we get the result faster in 2 to 4 weeks. And again, it can be done for both first and second line drugs. So this is just looking at the difference in timeline using solid culture and liquid culture. So for somebody with MDR-TB, if you use a solid culture, your diagnosis takes about 9 to 12 weeks, which is almost 3 months to make a diagnosis of MDR-TB, which is a very large amount of time, considering the fact that this patient is likely to spread the disease to others and not get appropriate therapy for this period of time. Using a liquid culture, this time can be reduced significantly to 3 to 6 weeks, which in itself is a great achievement. But still, this is a long period of time. For XDR-TB, for diagnosis, if we use the solid culture, it takes 12 to 16 weeks. And if you use liquid culture, it's about 4 to 9 weeks. So really, we're talking about tests that are taking a long period of time to actually come to the diagnosis. And over the last 10, 15 years, there's been a significant push to develop actually molecular diagnostic tests. And we need these tests because we want to rapidly diagnose tuberculosis, and we also want to rapidly diagnose drug-resistant tuberculosis. Because the best way to prevent transmission is actually to treat the patient and make them sputum and culture negative. So conventional methods are just too slow, causing a lot of delays, and patients really don't get the appropriate treatment till the diagnosis is made. And that is why these molecular methods have come up in the last few years. These are very sensitive and specific, and they can detect resistance mutations in bacterial isolates as well as in clinical samples. The most popular and the well-known of these is the Gene Expert or the Expert MTB RIF assay. We now know that this expert platform has been broadly used for diagnosis of a lot of other disease conditions, including COVID, including multi-drug resistant gram-negative infections. So this platform really has changed, infectious disease diagnostics. And what does it do? It does two things. It detects MTB, so it's used for the rapid detection of Mycobacterium tuberculosis, and it also tells us whether there is rifampicin resistance. And this rifampicin resistance is used as a surrogate marker for multi-drug resistant tuberculosis. And what is the great advantage of this test is that the turnaround time is only about 1 to 2 hours. So you get your diagnosis of TB, plus you know whether this is drug-resistant TB, all in a couple of hours versus waiting several weeks for the same diagnosis to come. So it's a fully automated test. It uses a cartridge-based sample preparation with amplification and then detection, and it's based on a multiplex nested real-time PCR. And it uses a series of molecular beacons to simultaneously detect the presence of MTB and to diagnose rifampicin resistance. I'll try to simplify this and explain it a little more in the next couple of slides. So this is the RPOB gene. Sorry, this is the RPOB gene. It is an 81 base pair rifampicin resistance determining region. And this gene expert uses 5 probes that actually look at different areas of this rifampicin resistance determining region. And these 5 probes actually look at the nucleic acid sequence and bind to the probe sequence. And they bind only to the wild type or the susceptible type. And once they bind to these probes, there is a fluorophore or there's a fluorescence produced, and there's a light produced, and we know that it is a susceptible TB. So in the presence of resistant TB, this binding of the probe does not happen, and this fluorescence does not occur, and we know there is drug-resistant TB. So just to show you what it would look like, if you look at this this graph, you can see there are 5 different sort of S-shaped curves, and each of these actually represents one probe. And in this first graph on top, all 5 probes are actually amplifying, and this means there is drug-susceptible TB. So if you look at the graph, the lower graph, you will see that there's one probe that is flat, the green colored probe. I don't know how clearly, but then you can look at it carefully, you will see it. This actually does not amplify, and this means that this is not susceptible TB or not wild type. This is actually drug-resistant TB. So if any of these probes, and they're named A to E, if they fail to amplify, it usually means drug-resistant TB. So that is about the gene expert. Very rapid test, quickly tells us about rifampicin resistance and the presence of MTB, which is used to as a surrogate marker for multi-drug resistant TB. So this is just a pictorial representation. You have a sputum sample. It undergoes liquefaction in inactivation. This is the kind of cartridge that is there. You put 2 ml into the cartridge, put it into the machine, and the machine actually just does the rest of the work. The sample is washed, and then there is a release of DNA, and then the DNA molecules mixed with the PCR reagents, and then there's a real-time PCR run, and you get a result like this. So very, very simple to do. It doesn't require a big setup, and you get the result in 2 hours. And so this cartridge-based test is something that has really revolutionized TB diagnostics. So this has been around for about 10 years. And over the last couple of years, they've gone one step ahead, and they've come up with something called Expert Ultra. What is the advantage of this? The Expert Ultra has this higher sensitivity, which is important because it will pick up more number of cases, 5% higher than the regular Gene Expert, and especially so in patients who are smear negative and who are HIV infected. Unfortunately, with this increase in sensitivity, something had to give, and the specificity is a little lower, it's about 3.2% lower. And this specificity drop is more in patients who had a past history of TB, and it's also there in patients with no history of TB. So these are what we call false positives. So patient may not really have TB, but the test comes positive. So specificity was a little lower. But its ability to detect rifampicin resistance actually remained the same. So what is WHO or World Health Organization's recommendations for Expert Ultra? This Expert Ultra uses the same machine as the Expert. It just requires a separate cartridge and a new software. So wherever possible, WHO has said to move to Expert Ultra, especially for four categories of patients. Smear negative, culture positive patients, it performs better. Pediatric patients, it performs better. And you will realize that for pediatric patients, the quality of sputum sample and the quality of the sample that is given may not be as good as in adults. Extrapulmonary specimens, particularly CSF, this test performs better, and specimens of HIV infected individuals. So these are the problems where we have challenges in TB diagnostics. Extrapulmonary TB, TB meningitis, very difficult to diagnose and prove microbiologically. So this test may actually help by improving the performance of performance in CSF and in people who are HIV infected. Another of these neuromolecular tests is something called the line probe assay. There are two commercial assays, the LIPA-RIF TB assays and the Haynes MTB DR plus and SL assays. What this does is this can detect resistance to 2 first-line drugs and 2 second-line drugs. So it looks, the 2 first-line drugs, it detects resistance to is isoniazid and rifampicin, and the second-line drugs is to fluoroquinolones and the second-line injectable agents. So it uses a PCR technique plus a reverse hybridization on the strip with DNA probes. So without trying to confuse you or go into too much details, basically there's DNA extraction from the sample material. This leads to free DNA lying in the tube. Then there's amplification and denaturation, and then there is a process called reverse hybridization. And actually, you get the results in the form of bars that are printed on a strip, which tell you whether there's wild-type virus or there is a mutant virus. And you can do this for 2 first-line drugs such as INH and rifampicin, and 2 second-line drugs which are fluoroquinolones and injectables. So I'm not going to go into this algorithm so much, but all I want to emphasize to you is, if you look at algorithms around the world, including RMTCP, you will see that incorporated into this are all these molecular tests at a very early stage. So CBNAT is equivalent to the GeneXpert, it's cartridge-based nucleic acid amplification test. And this says that anybody with suspected TB should have a CBNAT test done, or it should have a GeneXpert done to distinguish between rifampicin resistant, rifampicin susceptible TB. So this is for pulmonary TB. Similarly, if you look for extrapulmonary TB, again, incorporated into the guidelines very early is the use of CBNAT. So important is liquid cultures should be sent for a patient who is suspected to or who is potentially has tuberculosis. So I would advise you to look at these guidelines later if you are interested. I'm not going into these, but just to tell you that these have been incorporated into national guidelines world over. Just a couple of words on newer diagnostic tools, and these are coming up in a big way. I mean, it may sound like big words, but it's not very difficult to understand. See, when you do a GeneXpert or a line probe, you can only detect resistance to 1 or 2 drugs. So why not find out the resistance patterns for all the drugs? And for that, we need to sequence. We need to do sequencing of the organism, and it will help us for identification and typing, and also genetic analysis of mutations. And one of the ways of doing the sequencing is a method called pyrosequencing, which basically involves DNA sequencing in which pyrophosphate is released during DNA synthesis. And the advantage of this is that you can look for resistance mutations to a large number of drugs or to several different genes at the same time. You don't have to just do rifampicin or just do INH. You can select what genes you want to look at, and different resistance mutations you can look at all at the same time. So obviously it tells you a lot of information much faster, but it comes at a price, and it comes at real skill in operating these kind of machines. Availability is also poor, but this may be the future of where things go. Along with this, there's also something called whole genome sequencing, where you actually sequence the entire genome and look and compare it to standards that are available worldwide or a genome library. So this is again something that in the next few years it may become. Whole genome sequencing is used for a lot of diagnostics. It can be used for infectious disease diagnostics. It can be used for other conditions, genetic conditions. But in TB, it is used from a culture, and you look at the entire sequence of the genome, compare it to an already available pattern on the library, and then you will be able to come to what are the different mutations that are available. So pyrosequencing and whole genome sequencing are some of the newer methods that actually the world is actually moving to, and over the next few years, maybe we will also move in that direction. So radiology, I mean, we can sit and talk for hours about the different radiology that we see with TB. So from pulmonary TB, from cavities to miliary TB with miliary mottling, pleural effusions, pericardial effusions. You have ring enhancing lesions or tuberculomas in the brain, and you have, port spine associated with vertebral collapse and paravertebral collections. So depending on the site involved, there is different forms of radiology that have been described, from plain X-rays to CT scans to MRIs. One thing you need to realize is that radiology gives us only a pattern. Radiology doesn't give us a microbiological diagnosis. And yes, we can say that this X-ray on top in the center looks like miliary TB, but actually that's not right. All we can say is that there is miliary mottling. And the differential diagnosis of miliary mottling, one of them is definitely tuberculosis, but cancers, other, like fungal infections can also present with miliary mottling. So this just gives us a pattern of sort of disease presentation and the site that is involved, but it does not tell us microbiological etiology. So its diagnostic value is far less than what we send at microbiology. Histopathology, again, something that we very, very commonly rely on. And we have to rely on this because other than the pulmonary form of TB, which is the multibacillary form, all the other forms of TB that I just talked about are all quasi-bacillary disease. So the chances of you finding actually viable bacilli either on microbiology or on diagnostic tests is actually quite low. And so we have to use other tools. One of them I mentioned is radiology, another is pathology. And there are some classic descriptions from our pathologies days. You'll remember caseating granulomas. There's usually caseous necrosis. The gross specimen will have some chalky cheese-like material in the center. So these are just some of the slides of caseous necrosis that you will see. You will see granuloma formation with epithelioid histiocytes, Langerhans giant cells. So when you see granulomas, you think TB, but again, there are a lot of other granulomatous diseases like sarcoidosis, like invasive mucormycosis, melioidosis, even a lot of infections like endemic mycosis, histoplasmosis. All of these cause granulomas. So yes, granulomatous disease is highly suggestive of TB, but please remember granulomatous disease is not equal to TB. So we need a constellation of histopath, radiology, microbiology when we're dealing with the tuberculosis suspect. And many a times the diagnosis may be straightforward, but you can understand why it is complex, because it is not always that the microbiological diagnosis will confirm the disease. So now I'll move on to actually principles of treatment. And I'm not going into the great depths, but I'm mainly going to just focus on the principles of treatment and why we do what we do when we treat TB. So our main aims when we treat TB is eradication of disease, obviously. We want to prevent transmission, and the best way of preventing transmission is actually to treat an active case of TB. We want to prevent relapse of the disease, and we want to prevent emergence of drug resistance. So there is no TB regimen worldwide that has only one or two drugs. It is always a combination of drugs, and usually it is a combination of either 3 or 4 drugs that is given for a long duration of time. The treatment is not easy, it is complicated. Almost all regimens have what is known as an intensive phase, which is for the first 2 months, and usually several drugs are given there. And then you have a continuation phase, which continues from anywhere from 4 to 7 months and maybe extended even longer based on the clinical situation. Let's be very clear that there is no role for intermittent therapy anymore. Multiple studies have shown that the chances of failure, relapse, and drug resistance is very high. We used to follow this in DOTS about 10-15 years ago, where we give alternate day therapy or thrice weekly therapy. There's no role for intermittent therapy anymore. So it's a combination chemotherapy. In the intensive phase, we normally use 4 drugs like isoniazid, rifampicin, ethambutol, pyrazinamide. This may be modified depending on a lot of conditions, tolerance, coexisting diseases. So standard is we use these 4 drugs. And why we use these 4 drugs is to actually prevent the emergence of resistance. In the continuation phase, we use 3 drugs, and this has been changed recently. We use INH, rifampicin, and ethambutol. And we use 3 drugs because we are worried about INH resistance. And in the community, it's about 20%. And whenever the INH resistance is more than 5%, we would like to use 3 drugs in the continuation phase so that in the situation that there is INH resistance, the patient is not just on a single drug. Duration of therapy, it's 6 months for pulmonary tuberculosis, extrapulmonary TB, disseminated disease, HIV infection, it's anywhere between 9 and 12 months. There is no hard and fast rule for when to stop anti-tuberculosis therapy, but generally for extrapulmonary TB, 9 months should be enough. Same goes for HIV infection, maybe 9 to 12 months. Some special situations like cerebral tuberculomas or bone and joint disease, people tend to treat for longer, even from 12 to 18 months. But there is no real guidance that says that this is what has to be done. There are challenges to treatment. These drugs are not always safe. They have their own toxicities. So drug toxicities are a problem, especially the liver toxicity is the one that is the most problematic. Isoniazid, rifampicin, and pyrazinamide have liver toxicity. Ethambutol causes problems with the eye. It causes problems with color vision. What about people with renal insufficiency, with decompensated liver disease, treatment in pregnancy? All these situations are actually special situations and are challenges to treatment. A lot of drugs interact with the anti-TB drugs, including antiretroviral drugs, anti-epileptics. So you have to be very careful with what drugs you choose and how you're giving them, and make sure that you have a good drug history before you introduce any of these new drugs, because they do cause drug interactions. What about adjunctive therapy along with ATT? Yes, steroids are definitely beneficial in certain specific situations like tuberculous meningitis, where it is proven to have a mortality benefit. In tuberculomas in the brain with surrounding edema, steroids are used to reduce this edema, and also for pericardial effusions to prevent constrictive pericarditis, steroids have been shown to be useful. Some patients may need adjunctive surgery, especially in situations and complications like port spine, when there's significant bone and joint involvement, or there is tuberculomas with associated hydrocephalus. There may be a need for surgical management as well. I'm going to just briefly talk about drug-resistant TB, because that's a major problem. And I'll probably spend the next 5 minutes talking about that, and then I'll wind up. What do we mean by drug-resistant TB? And when we say drug resistance, it means that the TB strain has resistance to at least isoniazid and rifampicin. And that is what we say when we say this MDR, we go on saying MDR TB is resistance to at least isoniazid and rifampicin. XDR TB is resistance to isoniazid and rifampicin, as well as to fluoroquinolones and at least one of the 3 injectable drugs, that is amikacin, kanamycin, and capromycin. That is XDR TB. And pre-XDR is a term we use when there is resistance to isoniazid and rifampicin and fluoroquinolones or injectable aminoglycosides. So these are the terms that we actually commonly use. So just to demonstrate the seriousness of this problem, I'll just go through this case. A 17-year-old girl from Sikkim who really had no history of TB in the past, presented with 5 months of cough, fever, and expectation, and 1 episode of hemoptysis, and significant loss of weight and loss of appetite. On examination, there was some bronchovascular breaths on the right infraclavicular region with few crackles. You can see the X-ray, and you can see that in the right upper zone, there appears to be a cavity and some infiltrate. So from what we said, pre-test probability or suspicion of TB in this lady, in this young girl, is extremely high. But what we did not expect is this result. So sputum smear sent for AFB showed a scanty AFB and 2+ AFB. The sputum sample gene expert detected MTB and also detected rifampicin resistance. So a line probe assay was done, which showed susceptibility to fluoroquinolones and aminoglycosides. So as per our definition, there is resistance to rifampicin, and on the culture, there is resistance to INH. So this is multi-drug resistance TB. Multi-drug resistance TB. And subsequently, if you look at the culture, you will see that this strain is resistant to isoniazid, rifampicin, ethionamide, streptomycin, and ethambutol. So it's resistant to a lot of drugs. So multi-drug resistant TB is a serious problem that is actually increasing in our country. It is constitutes about 7% of all tuberculosis patients, 3% of newly diagnosed tuberculosis patients, and about 11% in patients who previously had TB. This is a very challenging and difficult infection to treat and eradicate. So early diagnosis is actually paramount. And what I have discussed in the diagnostic tools, such as Gene Expert, Line Probe, and the newer diagnostic methods, will all help with an early diagnosis of multi-drug resistant TB. So what is our goal when we want to treat MDR-TB? Obviously, the primary goal is to eradicate the infection and treat the patient. But along with that, we want to use some drugs that are less in number and have less toxicity, and preferably we want to avoid any agent that is an injectable agent. So what is the main impact on outcomes in MDR-TB? And if you look at this table, it will show you that if they are sensitive to aminoglycosides and fluoroquinolones, the treatment success rate is about 73%. If they're resistant to both fluoroquinolones and aminoglycosides, the treatment success is only 51%. Obviously, HIV infection, the treatment success rate is only about 55%. So over the last 3-4 years, there are several new drugs that have emerged for the treatment of multi-drug resistant TB. And one of these is bedaquiline. It's a new oral diaryl quinoline drug that inhibits the ATP synthetase of MTB. It has very similar bactericidal activity to rifampicin, INH, and pyrazinamide, and it has a sterilizing activity comparable to rifampicin. It does have some cross resistance with clofazimine, and it has very serious cardiotoxicity in the form of QT prolongation. The other group of drugs is from the nitroimidazoles group, and these are delaminid and proteomanid, and they inhibit mycolic acid synthesis and also liberate toxic nitric oxide within MTB. Again, this causes QT prolongation, and it should not be used whenever there is metronidazole allergy. Protomanid is a nitroimidazole derivative, and it has been shown to be useful in combining it like a synergistic effect with other drugs, and it has a cross resistance with delaminid. So in about late 2018, WHO came up with a complete revision of the MDR-TB guidelines. And previously we had several classes of drugs, and the class A and class B was the fluoroquinolones and the injectable aminoglycosides. And these two formed the backbone of MDR-TB treatment. But now they completely changed it, and these are the current guidelines, where the drugs in group A are one of the quinolones, that is either moxifloxacin or levofloxacin, bedaquiline, and linezolid. And group B, clofazimine, cycloserine, or terazidone. And it is recommended to include all 3 medicines from group A and both medicines from group B. And then subsequently, you complete the regimen using other drugs such as ethambutol, pyrazinamide, amikacin, ethionamide, and delaminid. So there is a complete shift and turnaround in what actually WHO has recommended over the last couple of years. So MDR-TB is a very challenging infection to treat, primarily because of the duration of treatment, and secondly, because of the kind of drugs we use, which are very toxic. So this study came out way back in 2010, done in Bangladesh, where they looked at a short course, about 9 to 11 months of treatment for MDR-TB. And they showed that the success rates are fairly good with this regimen, using 4 to 6 months of kanamycin, moxifloxacin, prothionamide, clofazimine, pyrazinamide, high-dose ionizing ethambutol in the intensive phase, and then fewer drugs in the continuation phase. So there were a lot of questions about that study, and WHO has come out with a standpoint regarding this shorter course MDR-TB guidelines. And what they say is that we can only use this for pulmonary MDR-TB, and there are several conditions that must be fulfilled before we can even think about this short course MDR regimen. Whether there is resistance or suspected resistance to any of the medicines in the shorter course regimen, is there exposure to any of these drugs that we're going to use, is there intolerance to any of them, pregnancy, extrapulmonary disease, and non-availability of drugs also ensure that we cannot use this regimen. So yes, there may be a role of shorter duration MDR regimen, especially on a programmatic basis, but there are a lot of conditions that actually need to be fulfilled before we can move to that. So I'm coming to the end of my talk here, and let's revisit the questions that we started off with in the initial case that we discussed. Can it be tuberculosis? We talked about the epidemiology and the clinical manifestations. So yes, the first patient I presented can be TB. How do I confirm the diagnosis? We went through the list of diagnostics available from the diagnostic tools available historically to the more recent ones. What test should I order and what samples to send? We discussed that. Can this be MDR-TB? We talked about MDR-TB in brief. And what treatment should be started? So hopefully we are in a better position to answer these questions now. So my take-home message today is tuberculosis is rampant, and it can present to anybody. It can present to an internist, it can present to an orthopedician, ophthalmologist, obstetrician. It can present in a variety of ways, and it has really protean manifestations. And unless you're thinking about it, you're likely to miss the diagnosis. There are a lot of newer diagnostic tools available over the last few years that have really helped make the diagnosis of TB much earlier. And it is up to us to know about these tools and actually use them in the best possible manner. Therapy is long. Drug toxicities do exist, and drug interactions also are there. And so therapy is definitely challenging. Keeping somebody adherent to these drugs for such a long time is also challenging. But there are newer drugs and regimens which promise shorter durations of treatment and less toxicity. So hopefully at the end of this, you are not feeling like this, a feeling of impending Zoom. With that, I will conclude my talk. And yeah, if there is any questions or discussions, and I'll be happy to hear from the other panelists as well regarding their experiences and their outlook. Thank you.
Thank you so much, Dr. Karthik. That was an amazing talk. Over to Dr. Jensi, ma'am. Sorry, over to Dr. Aji Matthew.
Thank you, Dr. Rajiv. So that was an excellent talk. I think you have covered everything regarding the diagnostic and the management part of tuberculosis, covering all the updates as of now, going from the basics and on towards the genome sequencing and also all the newer therapies, bedaquiline, protomanate, all those drugs. So that was excellent. And also I thank you for choosing this topic. That would be refreshing from our point of view, as we have been seeing and hearing COVID all around the walls since almost the past 10 or 12 months. So I'm not wasting my time. So coming to the topic, yes, we have been treating this disease quite comfortably over the years. When you have patients presenting with, when you label them as a new case, you have direct case, the patient is coming, you diagnose by your smear microscopy, yes, and your CBNAT or gene expert is showing it as to be drug sensitive tuberculosis. That is one part. But the next term would be You have a previously treated patient, and then you go for the gene expert, and then if your gene expert comes negative, and then your culture gene expert comes positive, and you see for your culture report, your AFP culture is negative. And if the patient has got minimal symptom with gene expert positive, culture negative, minimal symptom, and not belonging to that group of high risk suspicion for MDR tuberculosis, do we need to wait for maybe a repeat gene expert and see if it gets converted, or you want to label him as a tuberculosis or MDR TB and go on with your regimen? So you take on false positives with gene expert.
So yeah, I totally agree with you. That's a very challenging situation where you have somebody who is ATT naive, who has never taken ATT, and then comes to you. You do a diagnostic test, and the gene expert is positive, and it shows rifampicin resistance, versus somebody who's already treatment experienced. So we know that there are risk factors for developing MDR TB, and prior history of ATT intake is one of them. My take is, unfortunately, for pulmonary TB, I think it's different because it's a multibacillary disease, and we're likely to get a culture that may be positive. But for extrapulmonary TB, I think the situation is different. The yield from many of the specimens for extrapulmonary TB is actually quite low. So especially the patient is already having symptoms and having disease, um, uh, repeating a gene expert after some time may not entirely give us the answer. And with that, we're also sort of, we are delaying sort of the treatment. So unfortunately, when we have these kind of molecular tests, we are bound to be, we're bound to run into these problems where there are some false positives and there are some false negatives as well. So I think overall, it's difficult to say, a uniform basis what is to be done. But I think we need to look at each individual case and look at the patient, look at the symptoms, look at whether he is able to come for follow-up, what are his risk factors, and then decide what sort of treatment regimen that we want to start on.
Okay, so thank you. So I think that includes a high clinical suspicion also as a diagnostic tool before you jump into labeling him as a TB. Sir, also you mentioned about the newer diagnostic modalities. Can we expect to have our Gene Expert Ultra anywhere in the near future, or has it got anything add-on benefit? I mean, we consider to Gene Expert MTB.
So for the last several months, we are actually completely moved to Expert Ultra in our setup. And what it does add is that it does add a little bit of improved sensitivity. So especially for extrapulmonary specimens, for CSF, and for pediatric specimens, it's shown that there is a little bit of improved sensitivity. But unfortunately, with that increased sensitivity, the specificity actually drops. And we have definitely seen several false positives, which actually come as Expert Ultra trace. That's what the report says, and you're not able to make out whether there's rifampicin resistance or not. So we have seen definitely more false positives than the expert. But when you're looking for an increased sensitivity, it has to give somewhere. And with that, we have lost specificity, especially in patients who are already on treatment or patients who've been treated in the past. And we found that this false positivity comes when somebody has a clear alternate diagnosis, like somebody with a lymphoma or somebody with a clear alternate etiology. False positives definitely do come. So we have to trade that increase in sensitivity with a small drop in the specificity. And again, look at the clinical picture. Yes. If you have done the test suspecting TB as your first diagnosis, then yes. But then if TB is nowhere in your diagnostic list and you've done your bone marrow or done a lymph node biopsy with the diagnosis of lymphoma, and that is confirmed, and then there's a test that is positive, then you don't take it as significant. But some definite rise in false positives with the Expert Ultra.
So I think your clinical suspicion is not that high. With some amount of alternative diagnosis in your mind, I think it would be worthwhile to wait and treat if you can have any other curable disease rather than going in for labeling him as a TB. Sir, any
Yes.
experience regarding the newer MDR drugs like bedaquiline at your center?
So the thing is, we don't have access to any of these new agents, bedaquiline, proteominid. We actually don't have access to them. Even our DOT center does not have access to that. We have to send patients to Chennai, which is Tambaram, which is a large TB center. So we really don't have any access to or experience with these newer drugs. We do try to use linezolid as which is one of the drugs in the category A. So wherever possible, we try to use that, but we find that it is very limited because of its very, very high toxicity. So bone marrow suppression, peripheral neuropathies, that really limits our use of linezolid, and it's nowhere near what literature actually recommends using of linezolid for longer durations of time. We find that the toxicity is really limited.
Sir, one more thing: do you prefer treating LTBI patients who were contacts of TB, and also those patients, children of patients, gamma release assay or Manto test, and go for a treatment of LTBI, or you would want to wait for clinical?
So there are some group of patients in whom latent TB we definitely would want to go ahead and treat, and these are patients who one group is anybody who is looking to undergo a solid organ transplant, and other group is now everybody uses these newer TNF alpha antagonists for inflammatory bowel disease, rheumatological diseases, skin diseases. So anybody who's going to go on treatment for that, or who is going to get a solid organ transplant, or children who are, I don't really treat children with latent TB. We have a separate pediatric ID department, but I know they also do treat patients with family members or contacts of or children of those who have active TB. They do treat them for latent TB. So yes, your question is, do we treat latent TB? Yes, there are certain subgroup of patients who we treat latent TB for, but not otherwise, not in an otherwise normal healthy patient, or even somebody with diabetes. We don't treat. We know that isoniazid preventive therapy is integrated into the HIV program now. So everybody who's enrolled into an ART center gets isoniazid preventive therapy. So for that subgroup of patients as well, latent TB is being treated. So yes, definitely latent TB needs to be looked into, and we know in the HIV population it has significant benefit. So certain populations, yes, we would treat it.
Rajiv, I would like to ask you a question. See, especially in MDR TB, when you have a strong, when it's extrapulmonary TB, and when you have a strong suspicion of MDR, and all the more when you have made your initial diagnosis on a histopathological basis, now how do you go forward?
So that is extremely difficult. See, actually, if you look at the definition of MDR TB, it's actually a microbiological
It's a microbiological, yes.
But we've all seen patients not getting better with conventional TB treatment when we start thinking, is this MDR TB? You think because of prior ATT use, this guy has got a high likelihood of MDR TB. And there is no easy answer for that, because whenever we say MDR TB, we actually make the diagnosis is made microbiologically. And at some point, we all know when we deal with TB, whatever we do, we're not able to get that microbiological diagnosis. And at some point, yes, we have to use our clinical, how much ever we talk and discuss about microbiological diagnosis. There is a point that in each patient where we would have to use our clinical judgment, either not improving or the risk is very high, where we would have to take a call whether this is likely to be MDR.
So in your experience, have you committed to MDR treatment on this basis, on your clinical judgment?
If somebody is critically ill or seriously ill or has serious form of TB, yes. But if not, if it's just lymph node TB or something that's not life-threatening, we would just wait and see if the cultures come positive, and in that time at least see what the response is. But we've had patients who come in very sick, who've had disseminated disease, who've had CNS TB. So some of the life-threatening forms of TB, yes, you don't have the, unfortunately, you don't have the opportunity to wait for several weeks for the culture report and see them. So yes, we have started, and that is, I guess that is where, you've done everything possible to make a diagnosis of MDR-TB, but you're not able to. So you have to use your clinical judgment at some point in time.
This line probe assay, can we do it on all kinds of tissue, or is there some limitation for us?
So the line probe assay doesn't work well when you do it directly on a clinical specimen. Usually when there is, when the smear is positive with at least a few AFB, that is when the line probe assay works best. And actually our lab will not run a line probe assay on directly on a clinical specimen. They will just first do a smear. If there is, scanty or few AFB, then they can run the line probe assay, not directly on a smear, which is smear negative.
And what about for expert and all? Because earlier we used to say never use blood. We know we don't use. So what about bone marrow in that case?
Yeah.
So can we send bone marrow for expert? Is it like a correct thing to
Bone
do?
marrow
Because
you
it's
can
after
send.
all
Yes.
blood.
Yeah.
We can use it.
No, bone marrow is acceptable. Yeah, but we can't use it for peripheral blood or blood stain specimens.
Yeah. Oh.
Bone
That's why I
marrow we
was
can
worried,
send, yeah.
because blood stain specimen, they say don't use it.
Yeah.
But when we pull out bone marrow,
but
it's
bone
all
marrow
blood
is,
coming.
Yeah, I know. That's fine.
Yeah. But we can use it in
Yes.
bone marrow. Okay.
Yeah.
And one more question about treatment. See, this is something we know drug toxicity has always been a problem. And when we re-challenge one by one the first line drugs, and we are still getting liver toxicity, and we are stuck second time, third time challenge, and you are out with rifampicin, INH, and pyrazinamide, and it's a proven TB, how do you go forward?
So, especially in patients who have pre-existing liver disease, especially child pube C, you can't use any of the drugs. You're just really, your hands are tied. Or if you re-challenge and find that these drugs, you're not able to reintroduce them, then the only way is to use non-hepatotoxic drugs, but you have to use it for a long duration of time. It's almost 12 to 18 months. It's very challenging because you try to use an aminoglycoside for at least the first 2 months, but beyond that, it becomes challenging to use that as well. So you would definitely you would have to use a drug from the second line pool. Because there are only a set of first line drugs that we can use.
See, we usually put in quinolones very early in that case, like levoflox.
Yeah.
Is it, is it a good option to give something like ethambutol and levoflox and then give it for a long duration, or you have to put in one more drug along with that? Because RHZ is out.
Yeah, see, 2 drugs. I think at every point you would want at least 3 drugs on board. 2 drugs in the intensive phase I feel would be too less.
Once you go into continuation phase,
once you go into continuation phase, if you have no other options, the ethambutol and levofloxacin should be reasonably fine, because we are worried more about INH toxicity in the continuation phase, and that's why we give 3 drugs. Really, we're not that concerned as we are about INH toxicity, INH resistance, like we compared to ethambutol or levofloxacin toxicity. So again, it depends on a lot of things. What kind of TB does he have? Is it a serious form of TB? Is the patient very sick? So in TB lymph node or lymphadenitis, where we are well into the continuation phase, I would just stick with 2 drugs. But on the other hand, if the intensive phase also was not good, we could not give a lot of drugs. This guy has CNS TB, is quite sick. You may want to use one of the other drugs from the second line agents. Well, all of them also do have hepatotoxicity, but some of them like clofazimine, linezolid, all can be used. They have relatively less hepatotoxicity.
And what do you take as the endpoint for spinal TB, which has always been challenging? If there's a collection, okay, on radiological basis, it's resolved. But symptoms, we know it's going to persist. Little bit of backache is going to be there. But what do you take as the endpoint that you call it off?
So it's a composite of clinical, radiological, and I shouldn't say we. I use inflammatory markers as well to to go by how the patient has responded. There's always a composite, and what I found is actually the patients who have residual disease actually have persisting psoas collections or they have paravertebral collections. And our spine surgeons also have, I think they have an index which looks at several things on the repeat MRI to see whether this disease is active or not. I'm not exactly sure what all they look at, but they have certain, I mean, we look at, I know, the residual collections, but they look at several other things that actually say that this is healed disease versus this is active disease. And if they feel it's mostly healed disease, the symptoms have significantly, and symptoms won't go away, I agree, but they've at least significantly resolved. And you find that, from a very high CRP, the CRP is now undetectable or very low. Then you use these 3 composite markers, and then you say that if they've completed at least 9 months, then you say that, probably the treatment is enough, and then you stop. So I would stop at 9 months.
I feel orthopedicians are a little hesitant when we say stop it. Okay. Like they will say, can you just extend it for some more time? A difficult thing to answer at that point. Yeah,
that's true. For any extrapulmonary TB, it's difficult to follow up and say what is cure.
And Dr. Rajiv, I think there was a question which popped up about SGM use in pregnancy.
Yeah, I think, TB treatment during pregnancy, many of the drugs are actually okay, but yes, streptomycin, especially in the first trimester, would have its problems, and I would try to avoid using it. Unfortunately, streptomycin, amikacin, and the injectable aminoglycosides have significant hearing loss, which actually we see in MDR TB. And much of this hearing loss is actually, unfortunately, not completely reversible. So we have to be careful when we use injectable aminoglycosides, and you may, cure the patient of TB, but you will leave them with really permanent bad tinnitus and hearing loss. Some of them are very young people as well. So I think that is another reason why aminoglycosides are slowly moved out of the must-use group of drugs in MDR TB, because it causes a lot of toxicity, and one of these is definitely the ototoxicity and the tinnitus associated with it.
In Chennai, I mean not in Chennai, in Tamil Nadu, is more of MDR under the government sector, or do you also have a whole lot of them under your care? Because in Kerala, most of them, almost all of them would go under the RNTCP umbrella. Like
I think it's the same here. But, we get many of our patients not from Tamil Nadu, no? So we still have a huge cohort of patients who are under our care as well. But predominantly, you're right. They do go under, and we have to actually notify and fill in the, the details into that government program or app. Yeah, that has to be done. So, but we see so many people not from Tamil Nadu. We see from Andhra, West Bengal, Bihar. So we still have a large chunk of patients who come here, and we still manage them.
So the continuity of drugs and all, it will be from your place then.
Yeah. So we assess whether the patients will be able to come for follow-up and continue the treatment here with regular follow-up. If it looks challenging, then we would actually refer them to the government program.
Thank you, Rajiv. Aji, you have something else to ask, Dr. Aji?
Yes, so Rajiv, sir, one more question. So we have been using quite frequently steroids for whenever there is a meningeal or a pericardial involvement, or when you have a disseminated TB. But my question would be, is there any role for steroid in pleural effusion, oral steroid? Secondly, your comment on intrapleural instillation of hydrocortisone for pleural effusion.
So definitely, see, I think in TB pleural effusion, there are 2 kinds. One is the sterile pleural effusion, which is mainly like a hypersensitivity reaction, and the other is tuberculosis empyema. So definitely, there have been several studies that look at the use of a short course of oral steroids. Basically, what it does is it hastens your symptom relief. So fevers, cough, pleuritic pain, and resolution of pleural effusion actually has been shown that it is actually a little faster. But it doesn't, sort of change hard outcomes like, cure rates or mortality benefit or anything of that sort. So yes, symptom relief, it probably works. I use it on and off when somebody has very distressing symptoms, a lot of high fevers, pleuritic pain, you can give a short course of steroids. I think there's been enough of sort of evidence that shows that. I don't have any experience with the intrapleural instillation of hydrocortisone. Maybe you can share your experience with that.
No, I don't have any experience as a, so you said, so you just want to taper it off maybe within a period of 2 weeks, so you don't want to extend it over 4 to 6 weeks?
No, even if I give it maximum 2 or 3 weeks, it's mainly for symptom resolution. The fevers go away, the pleuritic pain gets better, and sort of the pleural effusion also sort of gets resolved better. So especially in people who have distressing symptoms, I would use it. I mean, I would say that I don't use it very often, but yes, that's an option.
But I think it's not going to prevent your your pleural.
No, it's not going to present. It's not going to change your cure rates. When you see at 6 months are patients cured or not, whether they take steroids, and that's not going to change. So it's mainly for symptom relief, improving your patients, feeling a well-being. So in certain patients who feel very, very, moribund and they don't feel well, yeah, you could use it. And I have definitely used it for some patients in my practice. But I don't have any experience with the intrapleural instillation. And I don't think our pulmonology department also has been doing that. I don't think so, as far as I know.
Ma'am, any more questions, ma'am?
No, good. He has cleared all our doubts. That has been really good, Rajiv. I think I'll hand it over to Jacob.
Ma'am, did we touch the... there's something about the benefit versus risk ratio. Do we have to?
That's what he was talking about streptomycin in first trimester versus second trimester.
All right. Thank you. So thank you so much, Rajiv Karthik sir. That was an amazing session. We are really grateful for that beautiful talk, especially during this time where we have very less time, COVID times, crazy times, right? So thank you so much, sir. Thank you so much. I would like to register my gratitude to Dr. Anulekha ma'am, your batchmate, who connected you to us. Special thanks to Anulekha ma'am. And thank you so much, sir. Thank you. Looking forward to yet another brilliant session from you down the lane. Thank you. And yes, sir. And Dr. Ajay Matthew, you logged in from Bangalore. I mean, you were on leave, and thank you so much for that commitment to come in and moderate this session quite admirably and get involved in all these deliberations. Really grateful for that. Thank you so much. And finally, to Jency ma'am. Ma'am, thank you so much. I know how this evening hour is so precious for you, and you've accepted my request and come over and moderated this session quite beautifully. Special thanks to you too. And if there's not much more to discuss, I think we can call it a day. Thank you so much, everybody. And also for the participants, thank you guys for participating. And on the 18th, we have another webinar on medication errors. Medication errors is one area where all doctors and medical professionals really have a trouble with. So we have a distinguished faculty from Calcutta. He is a medical director of Peerless Hospital, Dr. Baumik. So he's a specialist. He's a specialist in patient safety. So he is going to talk about the novel methods and various initiatives to curb medication errors. I think that's going to be a very interesting session. So see you for that session. And until then, thank you so much, everybody, and have a blessed evening. Signing off from Believers Church Medical College Hospital. Thank you so much. God bless.